Hi all! In this video, we will be discussing the article Global Health 2035, A World Converging Within a Generation. My name is Sammy, and I will begin with a little bit of background on the article, as well as the key messages and opportunities these messages have. Then I will turn the reins over to my colleagues, Laura and Brad, to discuss the new framework for Global Health 2035. Global Health 2035, A World Converging Within a Generation, is an article that was published in The Lancet in December 2013. For a little bit of background, in case you don't know, The Lancet is a family of journals that is focused on making science widely available to people. Its core belief is that medicine must serve society, that knowledge must transform society, and that the best science must lead to better lives. Prompted by the 20th anniversary of the 1993 World Development Report, a Lancet Commission revisited the case for investment in health and developed a new framework to achieve dramatic health gains by 2035. In 1978, the World Bank initiated an annual flagship publication, the World Development Report, or WDR, which aims to inform global thinking on a specific topic. WDR 1993, Investing in Health, was the only WDR that was focused on global health. WDR 1993 was the first major health report that was targeted at finance ministers and still remains one of the most widely cited WDRs in World Bank history. WDR 1993 argued that allocation of resources towards cost-effective interventions for high-burden diseases offered a rapid and inexpensive pathway to improvements in welfare for citizens. The 20th anniversary of WDR 1993, Investing in Health, prompted the research and updating of the plan. This leads us to Global Health 2035. The commission who took on this update was to consider the recommendations from WDR 1993, examine how the context for health investment has changed in the 20 years since publication, and develop a forward-thinking health policy agenda targeting the world's poorest populations. As of 2013, when the report was published, development assistance budgets were strained. At the same time, the economic growth of many low and middle-income countries has allowed countries to invest some money into their own development. This development is turning its focus from infectious diseases toward non-communicable diseases. The question the article aims to answer is this: how should low and middle income countries and their development partners target their future investments in health to tackle the complex array of challenges each country is facing in regards to global health? To start off, there are 4 key messages the Lancet Commission would like to focus on. In addition to these messages, the Lancet Commission came up with opportunities for action for each message, geared toward the national governments of low and middle income countries and to the international community. These 4 messages are: first, there is an enormous payoff from investing in health. Second, a grand convergence in health is achievable within our lifetimes. Fiscal policies are a powerful and underused lever for curbing of non-communicable diseases and injuries. Progressive universalism, a pathway to universal health coverage, is an efficient way to achieve health and financial protection. Next, I will discuss each of these messages in a little more detail, as well as give some information regarding the opportunities the Lancet Commission came up with. There is an enormous payoff from investing in health. According to the article, the reductions in mortality account for about 11% of recent economic growth in low and middle income countries, as measured in their national income account. However, this account fails to capture the value of better health in and of itself. The value of additional life years, or VLYs, can be inferred from people's willingness to trade income, pleasure, or convenience for an increase in their life expectancy. Between 2000 and 2011, about 24% of growth in full income of low and middle income countries resulted from VLYs gained. By using a more comprehensive understanding of the economic value of health, there is a stronger rationale for increasing resources to be used for health. Opportunity 1 for this message is that if planning ministries used full income approaches, which included assessing VLYs and guiding their investments, they could increase overall returns by increasing their domestic financing of high priority health and health related investments. Opportunity 2 is that the investment of VLYs strengthens the case for allocating a higher proportion of official development assistance, specifically to development assistance for health. A unique characteristic of our generation is that collectively we have the financial and ever improving technical capacity to reduce infectious, child, and maternal mortality rates to low levels universally by 2035. A grand convergence is achievable within our lifetimes. Opportunity 1 states the expected economic growth of low and middle income countries means that most of the incremental costs of achieving convergence could be covered from domestic sources, although it is important to keep in mind that some countries will continue to need external assistance. Opportunity 2 is that the international community can best support convergence by funding the development and delivery of new health technologies and curbing antibiotic resistance. International funding for health research and development targeted at diseases that disproportionately affect low-income and middle-income countries should be doubled from current amounts, approximately $3 billion a year, to $6 billion per year by 2020. The core functions of global health, especially the provision of global public goods and management of externalities, have been neglected in the years since WDR 1993 was published and should again regain prominence. The burden of deaths from non-communicable diseases, or NCDs, and injuries in low and middle income countries can be reduced by 2035 through inexpensive, population-based, and clinical interventions. Fiscal policies are a powerful and underused lever for curbing of non-communicable diseases and injuries. In Opportunity 1, national governments can curb non-communicable diseases and raise significant revenue by heavily taxing tobacco and other harmful substances. They can also redirect finances toward non-communicable disease control by reducing subsidies on items such as fossil fuels. Investment in strengthening health systems to deliver packages of cost-effective clinical interventions for NCDs and injuries is another important national opportunity. In Opportunity 2, international action should be focused on provision of technical assistance in fiscal policies, regional cooperation on tobacco, and funding of population, policy, and implementation research on scaling up of interventions for NCDs and injury. The last key message is in regards to progressive universalism. Progressive universalism is a pathway to universal health coverage, or UHC, is an efficient way to achieve health and financial protection. The Lancet Commission endorses 2 pro-poor pathways to achieving UHC within a generation. In the first pathway, publicly financed insurance would cover essential healthcare interventions to achieve convergence and tackle non-communicable diseases and injuries. This pathway would directly benefit the poor because they are disproportionately affected by non-communicable diseases and injuries. The second pathway provides a larger benefit package funded through a range of financing mechanisms, with poor people being exempt from payments. In Opportunity 1, national governments would be able to utilize progressive universalism, which would yield high health gains per dollar spent, and poor people would gain the most in terms of health and financial protection. In Opportunity 2, the international community can best support countries to implement progressive universal health coverage by financing population, policy, and implementation research, such as on the mechanics of designing and implementing evolution of the benefits package as the resource envelope for public finance grows. Global Health 2035 points to the possibility of achieving dramatic gains in global health by 2035 through a grand convergence around infectious, child, and maternal mortality, major reductions in the incidence and consequences of non-communicable diseases and injuries, and the promise of universal health coverage. Good reasons exist to be optimistic about seeing the global health landscape utterly transformed in this way within our lifetimes. Next, I will turn it over to Laura to start the discussion of Global Health 35 and its investment plan.
Thank you, Sammy, for that background. As Sammy has pointed out, the 1993 World Development Report made its mark on our global healthcare landscape in a variety of areas. Today I will begin this presentation by talking about 3 areas of global influence of the World Development Report. I will begin with discussing the global health advancements and challenges we have faced over the past 20 years. I will then touch upon the importance of investments in health and review how we can address our global challenges with the development of stronger health systems and population-based policies. By 1990, dramatic improvements in health had been achieved through technological and medical advances in health systems, as well as economic growth. These achievements included vaccinations, decreasing annual deaths, smallpox eradication, increasing childhood life expectancy, and more. However, ongoing poverty and poor public policy decisions have prevented about 1 billion people in low-income and middle-income countries from sharing in these health gains. At this time, health systems were facing major problems, and healthcare costs were on the rise. The global HIV/AIDS pandemic had also taken hold. In 1993, the World Development Report proposed a 3-pronged approach to government policies, underpinned by investment in scientific research to advance each area. The first prong was to foster an environment that enables households to improve health. Global enhancing macroeconomic policies, expansion of schooling, and promotion of women's rights and status through political and economic empowerment and legal protection against abuse. The second prong was to improve government spending on health, targeting public spending towards a specific set of diseases and interventions such as HIV. Third was to promote diversity and competition in the supply of health services and inputs. For example, publicly financed services might in some cases be best provided by non-governmental organizations or the private sector. In addition, the World Development Report emphasized the importance of intersectoral action, particularly the value of linking health with water, sanitation, food regulation, and education. By proposing a vision for health improvement, a broadly applicable method for informing health policy priorities, which included combining disease burden with cost effectiveness, called for an agenda for action, and the World Development Report put pressure on other international agencies to respond. One important response was from the World Health Organization, who launched the World Health Report series in 1995. Several World Health Reports have followed since then. One identifiable effect of the 1993 World Development Report is that it motivated Bill Gates and Melinda Gates to invest in global health through the Bill and Melinda Gates Foundation to globally drive philanthropic programs toward health improvement. This foundation is the largest charitable foundation in the United States. It came into existence in 2000 when Bill Gates Foundation, founded in 1994, merged with the Gates Learning Foundation, founded in 1997. As of March 2007, the Bill and Melinda Gates Foundation endowment was estimated to be $33 billion US. The foundation concentrates on 3 main areas: global health, global development, and the U.S. program that includes education and access to technology for low-income communities in the United States. The foundation's global programs focus on improving health, reducing extreme poverty, and increasing access to technology in public libraries. The 1993 World Development Report generated the first estimates of the global burden of disease, otherwise known as GBD. By extrapolating estimates of death by cause worldwide in a way that was consistent with demographically derived totals, and by including an assessment of burden from non-fatal outcomes. Before this, countries were unable to accurately track their public health status. Now, with the existence of this report, this all became possible. While the influence of the 1993 development report was substantial, there remain limitations and challenges for the next 20 years ahead. In order to consider the challenges ahead, the Health Commission organized the issue into 3 interrelated domains. The first domain focused attention not only on low-income countries, but to lower-income and rural subpopulations of middle-income countries. The second domain focused on increasing rates of non-communicable diseases associated with the rise of behavioral risk factors such as smoking, alcohol consumption, and sedentary behavior, which are all compounded often by weak institutional arrangements to tackle these diseases and risks. Such injuries are the world's leading cause of death among people aged 15 to 29 years old. The third domain concentrated on the potential for impoverishing medical expenditures together with sharp and unproductive increases in healthcare costs, which, if not executed, can prevent achieving the other 2 domains. Since the World Development Report, important advances in health economics have been made to help quantify the value of investing in health. Health improvements can boost personal and national incomes as well as increase full income. The value of better health, or reduced mortality, is captured in the notion of full income. Growth in a country's full income in a period is the sum of income growth measured in the national income accounts, plus the value of change in mortality, or what you'd refer to as life expectancy in that period. According to past reports, improvements in health and nutrition have been associated with the GDP growth. Several macroeconomic studies done in the past 2 decades suggest that the effects of improved health on income at a national level might be even greater than the effects seen at the individual level. According to the historic microeconomic and macroeconomic studies, about 11% of economic growth in low-income and middle-income countries in the period of 1970 through 2000 resulted from reductions in adult mortality. The totality of this new evidence points to an important major conclusion. In the allocation of finite budgetary resources, making the right investments in health improves social welfare and stimulates economic growth. When health is valued inclusively with the methods described previously, the inclusively measured economic benefits of improved health are shown to be decisively greater than when health is valued only by its effect on national income accounts. The figure you're seeing is summarizing estimates of the contribution of health to growth in full income in 1990 through 2000, and in 2000 through 2010 for different regions of the world. Across low-income and middle-income countries as a whole, health contributes to annual growth in full income by about 1 to 2% per year of the initial value of GDP for the period of 1990 through 2000, and 1 to 8% per year in the period of 2000 through 2011. There are unprecedented opportunities for the national governments of low-income and middle-income countries to tackle infections and reproductive, maternal, child, and adolescent health disorders, to curb non-communicable diseases and injuries through essential packages with population-based and clinical interventions, and to provide financial risk protection through universal health coverage, while also taking steps to avoid unproductive health cost escalation. However, much of this progress can only be delivered through stronger health systems, which integrate primary care clinics, social, and community health workers, as well as hospitals, to create a seamless care continuum for patients. Many low-income and middle-income countries are struggling with insufficient resources and training to build the institutions and health workforce that are required to achieve positive health outcomes and therefore a stronger health system. The major health system functions such as service delivery, health workers, drugs, information systems, governance, financing, require substantial additional investment in all low-income and middle-income countries. There are too few doctors and nurses providing medical services in these income areas. Facilities then become under-equipped to provide high-quality care. The health system offers several platforms for delivery of packages of interventions for chronic diseases, disorders, and injuries. These platforms include community health workers, primary care clinics, first-level hospitals, and referral hospitals. Many diseases can be treated at a primary care level by primary care providers with the support from community health workers. In several countries, robust primary care clinics with qualified providers and a strong infrastructure with supply chains have proven to be an effective platform. In some countries, large-scale chronic care systems have been developed to provide HIV services in others. These may also be leveraged to jumpstart programs for chronic NCDs. However, these types of disease complications will also require district hospital emergency and surgical capacity. The primary care clinic, with its strong functional links to both the community and the district hospital, has an important role to play in clinical coordination across different care entities. Being able to provide a smooth and efficient care continuum for patients is what will make the health system stronger. Outside the health system, an important role exists for population-based policies to tackle the key risk factors associated with infections, NCDs, and injuries, such as poor water and sanitation, unsafe sex, tobacco use, and unsafe roads. 4 particular policy tools may play as primary influencers in health care outcomes. Those are taxes and subsidies, laws and regulations, information and communication, and improvements in the environment and the influence these factors have on managing risk in populations. These tools affect the uptake and quality of delivery of clinical services. However, relatively little economic evaluation has been done to assess the attractiveness of these instruments for improving clinical care. At this point, I will turn the presentation over to Brad Kruger, who will talk through the Convergence Roadmap, potential barriers, and resource mobilization. Thank you.
Sure. I'm in the 2015 Doctorate of Health Administration cohort at Central Michigan University. As Sammy and Laura have noted, a grand convergence in health is achievable within our lifetimes. There's a unique characteristic of our generation that provides the opportunity for a grand convergence to occur. Collectively, when the financial and technological resources from around the world are looked at, there is the capacity to reduce infectious child and maternal mortality rates to low levels universally by the year 2035 in order to achieve what has been termed a grand convergence in health. For the next part of the presentation, I'm going to touch on the convergence agenda. What should those targeted areas of focus be to achieve the convergence target for 2035? I'll also be talking about non-communicable disease and injury and how countries can avoid a paradox of success in global health improvement. That is, when low-income and middle-income countries improve infectious diseases associated with reproductive, maternal, newborn, child, and adolescent health, it looks like the disease burden quickly shifts to non-communicable diseases and injuries of adults and elderly people. In addition, we'll review health system finance and system health design and review how countries can mobilize resources to pay for health services. To wrap things up, the need for interventional collective action will be presented. While the financial and technological resources are available globally, there's a large gap in health outcomes between high-performing countries and low-performing countries. The graph above is a snapshot of one indicator of global health, mortality. It clearly shows the gap between countries with high mortality rates and those with low mortality. It also shows the impressive work done over the past 2 decades to bridge the chasm. As the Lancet Commission article notes, a key area of focus to improve mortality is to focus on infants and helping babies survive through ages 1 through 5. While there are many reasons for child mortality, many of them are preventable. These include mortality during birth, HIV, tuberculosis, malaria, and other tropical diseases. Let's take a look at each one and review tactics that can be used to improve mortality in low and middle-income countries. There are pregnancy-related interventions, which include antenatal care, treatment of pregnancy complications, delivery interventions, and postpartum care. There's abortion and complications. In many low-income countries, the complications from abortions are significant. There's family planning, diarrhea management, pneumonia treatment, immunization, and nutrition, specifically breastfeeding and supplementation. HIV, with an emphasis on prevention through education, effective management, continuing care and treatment, and a specific focus on tuberculosis and HIV treatment. Malaria, with a focus on early and sustained treatment, as well as prevention through spraying, insecticidal bed nets, and treatment during pregnancy. Along the lines of malaria, there is the diagnosis, sustained treatment, and prevention of other tropical diseases that are preventable and affect tropical low-income countries. Tuberculosis. Again, there's the diagnosis and the treatment, especially of multi-drug-resistant TB, or MDR-TB, which is resistant to two of the most potent TB pharmaceuticals. In the past 20 years, there are many bright spots. Bangladesh, Ecuador, Egypt, and Indonesia reduced their underage 5 mortality rates by at least 40% between 1991 and 2000. These outcomes were achieved by utilizing targeted health interventions and leveraging of development assistance for health programs. There is also Rwanda, who achieved a 60% reduction in the maternity mortality ratio and a 67% decrease in the under 5 mortality rate between the years 2000 and 2010. So what were these targeted interventions and health programs? The key to infant and maternal mortality is the first 28 days. The majority of newborn deaths can be prevented with key interventions around the time of birth and improved care for small and sick newborns. Antenatal visits and skilled caregiver attendance at birth are keys. In 2014, 71% of births were accompanied by a skilled attendant, compared to just 59% in 1990. Despite this progress, in 2014, about 36 million births from around the world in low and middle-income countries occurred without a skilled attendant present. As health coverage increases, attention is going to have to be paid to the content of care provided during women's and newborns' contacts with healthcare systems. There's also immunizations. Reducing vaccine-preventable illnesses and deaths relies on routine immunization programs that reach every mother and baby. Globally, 9 in 10 newborns now receive BCG and tuberculosis vaccine, and that's up from 8 in 10 in just 2000. Coverage of tetanus protection increased from 73 to 83%, and that of hepatitis B vaccine at birth has increased from 7 to 38%. Early and exclusive breastfeeding. Infants who are exclusively breastfed and those who begin breastfeeding soon after delivery have substantially better health outcomes. Globally, only 2 of 5 newborns are put to the breast within an hour of birth, and 2 out of 5 infants worldwide are exclusively breastfed for 6 months, as recommended, with large disparities occurring among countries. Postnatal checkups for mothers and babies. The majority of newborn deaths occur in the first few days after birth. These checkups are essential to address potentially dangerous postnatal complications and to provide nutrition counseling. Yet, less than 40% of women and a quarter of newborns in least developed countries receive a healthcare check within 2 days of birth. There's also diarrhea management. Improvements in drinking water, sanitation, and hygiene are reducing diarrheal infections. Today, more than 90% of the world's population use improved drinking water sources, and 2/3 use improved sanitation facilities. When children do fall ill with diarrhea, however, only 2 in 5 children receive the appropriate treatment, including oral rehydration salts. One of the other things listed was malaria. Since 2001, prevention, treatment, and elimination efforts have averted an estimated 6.1 million deaths from malaria in children under 5. Insecticide-treated bed nets are a simple, inexpensive method for preventing malaria transmission. However, between 2012 and 2015, only 45% of children in sub-Saharan Africa slept under one. Lastly, just want to point out undernutrition. Nutrition interventions that can help prevent stunting or reduce child mortality include the management of acute malnutrition, protection, promotion, and support of optimal breastfeeding, and complementary feeding practices. There's the provision of appropriate micronutrient interventions for mothers and children. Undernutrition remains a factor in nearly half of all under 5 deaths, and declines in undernutrition have occurred more slowly than declines in overall childhood mortality. One paradox of success in global health is that when low-income and middle-income countries successfully tackle infectious and reproductive maternal, newborn, child, and adolescent health diseases, they then accelerate the shift in disease burden to non-communicable diseases and injury, specifically in adults and elderly people. This chart shows the difference of NCDs, injuries, and mortality communicable diseases across countries based on combined income status. The red shaded segments identify the level of non-communicable diseases, which progressively expands as the income level of the country increases. What are some proactive and cost-effective population health and clinical interventions that low and middle-income countries could feasibly take the scale up to and significantly impact the health and economic effects of NCDs by 2035? The main determinants of MCDs and injuries can be grouped into environmental and behavioral risk factors, which can then be viewed through the lens of being potentially modifiable or non-modifiable risk factors. Examples of non-modifiable risk factors are a person's age, their genes, and fetal origins. Potentially modifiable risk factors include their psychological state, smoking, obesity, hypertension, and high cholesterol that causes hypertension, disease, and stroke. Effective low-cost drugs are available to control high blood pressure. For cancer, the interventions are hepatitis B vaccinations to prevent liver cancer, prevention of cervical cancer with low-cost screenings, and treatment of precancerous lesions of the cervix. For ischemic heart disease, stroke, and type 2 diabetes, the interventions are counseling and multi-drug therapy, usually aspirins, beta blockers, lipid-lowering drugs, and ACE inhibitors. For people who have had heart attacks or strokes, or at high risk of a cardiovascular event in the next 10 years. Various combinations of generic drugs for cardiovascular risk reduction can be packaged very easily into small, quickly distributed pill packs. In addition to behavioral-based risk factors, there are modifiable environmental risk factors. These can include air pollution, unsafe roads and vehicles, and cities built in a way that does not promote or could even inhibit physical activity. Another way to decrease smoking and alcohol consumption is through regulation on advertising. Who can forget the days when your doctor probably smoked a pack of Camels while treating you with emphysema on a hospital unit? Smoking and alcohol can be curbed through price changes achieved through a combination of taxes and eliminating subsidies. In addition, these sin taxes can be used to fund public health initiatives and help pay for effective interventions to reduce NCDs. Taxes on alcohol and tobacco to help pay for public health services is one way to achieve global health convergence. The challenge is, however, is the locations across the world that health resides in. These diseases continue to disproportionately affect people in the poorest countries, which account for the majority, 56%, of the global disease burden. For example, a person born in a wealthy country, such as Denmark, will live 78 years on average, compared with 39 years in a poor country, such as Sierra Leone, where the most deaths occurred between ages birth and 4. Health spending per person in income countries with more than 150 times what is considered to be low income, and more than 30 times after cost of living differences. The bulk of total health spending in low-income countries, 76%, is private, and more than 90% of private health spending is out-of-pocket. This is interesting because the opposite is true in high-income countries, where the majority, 60%, of total health spending is public and only 15% is out-of-pocket. Government health spending gaps have historically been addressed by international aid and development assistance, but if and where these funds will be dispersed remains uncertain. In addition, health spending estimates indicate that prepaid health expenditures will see the largest increases. The amount of dollars available for healthcare within a country will come down to priorities. With a limited amount of dollars available, it appears the two largest expenditures within a country are healthcare and military costs. This graph shows that many poor countries with lower health incomes in Southeast Asia, Sub-Saharan Africa, the Middle East, North Africa, and Eastern Europe spend more on the military than they do on medical. While the dollars are available to improve global health, the question is going to be the geopolitical stability of regions and a country's ability to shift resources from military to healthcare. To improve global health, it not only takes a village, it takes a village that plans together, communicates effectively, and mobilizes resources using a shared game plan. So let's look at the essential role for international collective action. These include development of new tools, such as technology, specifically smartphones, imaging, wireless networks, to medical and pharma solutions to diseases, and advanced point-of-care testing and diagnoses. There's pandemic preparedness. While influenza pandemics are unpredictable, history has shown there are consistent events that can cause severe social, economic, and political stress. Cross-continental advanced planning and preparedness are critical in helping to mitigate the impact of influenza epidemics or pandemics. A way international collaboration can help curb MCDs and injuries would be to collaborate with national and international health authorities to review taxation, trade, and subsidy policies that ensure that health considerations are receiving proper weight. Some examples may include tobacco taxation, tariffs on drugs, and oil subsidies. It will also be important to ensure that free trade agreements are not designed to limit national sovereignty with respect to control of substances that are harmful to a nation's population health. Based on the excellent progress the world has made to achieve health goals since the early 90s, there are good reasons to be optimistic about seeing the global landscape in healthcare completely transformed within a generation. With the advancement of technology, specifically the internet and smartphones, the pace of health improvement has been extraordinarily rapid. To quote John Lennon, "A dream you dream alone is only a dream. A dream you dream together becomes reality." Sammy, Laura, and I would like to thank you for your time today, and never forget, when it comes to impacting lives around the world, together we will.